Uh, what is neurology?
That place is scary, bro. Yeah.
Right? Psych
Yeah.
hospitals tend to be scary. Shutter Island.
Yeah. Don't they say that you're allowed to have one seizure in your life, though?
What are you guys seeing from a brain point of view?
You've only got a couple minutes, man, and then you start losing neurons.
All right, let's cook. We're cooking. Yeah. Welcome to the Loadshed Podcast. Today we have a really special guest. I've been scouting him for a few months. I did my background checks and then I finally got the confidence. I was in the change room actually at gym. This guy pulls up, bro, out the shower, 6-pack. I'm like, yeah, what is this guy? Is he a surfer? Is he a bodybuilder? What's going on? So I say to him, dude, yo, what do you do? He was like, what do you mean at gym? I was like, yeah, what do you do at gym? He's like, no, he just trains, push, pull, legs, I was like, yo, but like, the physique, bro. We got chatting, and then this guy so happens to be one of the smartest oaks I've met in the gym change room thus far.
I just want to say, if Josh didn't have conversations, we would probably never have a podcast.
Okay.
You know, if you didn't have conversations outside, we would never
So you
have
were
people to
actually
speak
scouting
to.
me out for some time prior
Yeah,
to...
so I saw you
Okay,
at gym
that I
a
did
few
not know.
times. I saw you at
Okay.
gym a few times,
Yeah.
and I asked the ladies at reception. I was like, hey, this guy, do you know him? She's like, no, but I think he's a doctor. So I was like, okay.
Okay. How did you know that?
I
Interesting.
don't know.
I don't talk to anyone at
do
gym.
you
You're
ever
like
wear
literally
scrubs to the
first-
gym?
Never.
Really?
Actually, never wear scrubs.
Okay, so they
I don't find them comfortable. They're like... I
They're
don't know,
not yours.
They're like thick. Maybe it's the size. The
There's-
sizing that doesn't work.
There's obviously a lot of mutters and chats at the gym that you never sort of hear. And then I was like, let me just ask him because it might just be confusing because this guy is definitely someone that I need to chat to because if he's not in the men's health cover soon, then we're probably going to get him somewhere else. But he's certainly
Are you
someone.
flirting with me?
Yeah,
Josh?
we're
It
just
sounds
a
like
bit,
it.
but then I saw that you brought your fiance here, so I was like, damn it.
Hi, Tash.
So, Wes, can we let you introduce yourself today and tell us exactly what you do?
Sure. Well, thanks for such a nice introduction. That was great, Josh. Yeah, I'm Wes. I suppose I don't want to... I suppose you start with saying I'm a doctor and all that, but I think a lot of doctors, the mistake they make is they make being a doctor everything about them. I try not to do that, but on the other hand, you know, when you commit so many years of your life to something, it's hard not to do that. But yeah, I'm a KZN boy. I'm originally from Durban, and I've been around different parts of the country, the continent since then, working. And I've come back to KZN. Happy to be back in KZN for the last couple of years to finish my specializing, basically, which is essentially complete now. So you could say I'm a neurologist, which is lovely. It was a long road, fun road though. Sure. I enjoyed it. It was, I think we'll go into the ins and outs of the kind of journey it is. But yeah, KZN boy, and my parents are in KZN.
Are you from a family of doctors or?
Not at all.
Really?
So that would be the first.
Okay.
Yeah.
Dr. Green.
Dr. Green.
Dr.
Okay.
Green.
Dr. Green.
When you guys do medicine, you end up choosing your path to which you specialize in. What inspired the neuro side?
Like I said earlier, it was a bit of a no-brainer, excuse the pun, but I think it's the kind of thing, once you're in neurology, you can't imagine being anywhere else. I always enjoyed, so there's a bit of a gap, a distinction in medicine between guys that go the medical route, so like physicians, and then guys that go the surgical route. And I was always more on the sort of medical physician side, enjoyed kind of internal medicine, but I liked a bit of everything. Didn't really have the personality for a surgeon, and obs and gynae was just the worst for me. I just couldn't do it. And more and more it led towards that way. And then I think having finished my time, rotated through, as you do with internship, community service, worked in Ghana, as I was mentioning earlier, you get a feel for what works for you. And yeah, neurology just fit for me because it's fascinating. It's kind of like you getting this privilege to learn the kind of things that a fraction of the world gets to learn, gets to see, putting that all together to help patients diagnosing quite rare conditions and yeah, like I said, having gotten into it, there's really nothing else I would have rather done. It's fascinating. I really enjoy it.
Were you always a smart kid, like at school?
Did do quite well at
That
school.
sound,
Yeah.
you know, when kids tell you they did quite
Humility.
well, you know, it's
It's a
nine A's,
95. It's a
nine
95.
distinctions.
It's a 95. He's
It's a
very
95
disappointed about
average.
the Mets not getting his 2% to make it 100.
Yeah.
What is neurology?
So neurology is the study of the nervous system. And yeah, maybe I can draw a distinction with neurosurgery here, because a lot of people say, I'll say, oh yeah, I'm a neurologist. I said, so, when are you going to start performing surgeries? Or
Yeah.
how long have you known that you wanted to become a neurosurgeon? So they're not the same. Both of them are doctors, specialized doctors. And up until the end of ComServe, so med school internship ComServe, you would all be on the same track. And then when you want to specialize, then you go your different routes. Neurosurgeons tend to manage problems in the nervous system, especially the brain, spinal cord, that require surgery. Think of a tumor, for instance. Think of traumatic injuries.
Yeah.
Whereas in neurology, it's more about the medical diagnosis, firstly. So finding out what's wrong, diagnosing them at the bedside. So we're more in the wards than in theater, if that makes sense. We are taking histories, diagnosing, and then localizing where the problem is based on what they're presenting with. And yeah, then we're managing them through medical means usually. So for example, let's say a patient comes in with a stroke. And by the way, if you have a stroke, you have 4.5 hours to ideally get in and have your clot busted. Thrombolysis, we call it. So they would come to us and we would deem whether you're a candidate for that or not.
What can you describe what's happening in a stroke? Sorry, while
So
you're
a
here?
stroke is a bit like a heart attack to the brain. So you're having a blockage in blood flow in a certain part of the brain. Usually it's a clot that causes what we call ischemia or an infarct, or it can be a bleed as well. And it's about 85%, 15% more likely to be an infarct. And when that happens, depending on which part of the brain is the blood supply is being reduced in, you will then have signs and symptoms related to that deficit that you're having.
So how do you know if you're getting a stroke for the average person sitting out there? Like, how do you know if a stroke's coming along? Is
Yeah.
there anything that you could look for?
Yeah, so you get different types of strokes, but I guess you can go on probability, right? And the most likely kind of stroke you're going to get is when you're weak on the one side, and we call that a hemiplegia, and might have facial weakness, you might have difficulty speaking. And the key is that it comes quickly, right? A lot of other things can give those problems, but they will come on a lot more slowly. Anything that gives you very rapid onset symptoms, and sometimes that can be bizarre. That can be rapid onset loss of vision, rapid onset vomiting, loss of balance, you name it. There's a long list of possible stroke presentations, but anything that comes on really quickly, just think, and especially if you've got the risk factors for a stroke. You're older, you're a smoker, you've got blood pressure, diabetes, maybe drink alcohol, you've had a previous stroke, you've got a family history, etc. Then those people are high risk, and you would be on high alert for those. But we're seeing it a lot in younger patients. So I work at Gray's Hospital. So shout out to the Gray's neurology team, great team. And there, because we are a specialized unit, we tend to see younger patients coming in with strokes because the older ones can be managed in the peripheries, and we don't have the capacity to manage, all of the 75-year-old diabetic hypertensives who happen to have a stroke because we just don't have the beds. So often we end up managing the younger ones, and then you need to look deeper for the cause because there's like 100 causes of a stroke. So that's where we come in, right? Try and manage the stroke acutely, chronically, and also try and find out why does this happen, and try and stop it from happening again through medication, rehabilitation, etc. So that's just an example of a stroke. But you can imagine if you look at the whole nervous system, there's a brain, there's you flexing your bicep like you do at gym often, Josh, and there's a pathway in between, right? And there's neurons, etc. So we need to know everything along that way and then back. So brain, spinal cord, roots, nerve, muscle, and everything in between. So you can have problems anywhere along that axis and on the way back. Even the eyes. So we deal with blindness and that kind of thing too, behind the eye, because remember the eye is attached to the brain via the optic nerve, right? So any problems along those axes would come to us.
Wow.
And so there's quite a lot.
Is there certain things that an individual should be consuming that could prevent the stroke, health wise? What could
Sure.
they do or consume
Yeah, or not consume,
or
right?
not consume?
Yeah.
Yeah.
Yeah, so like I mentioned, some of the vascular risk factors, we mentioned smoking and drinking. So certainly drinking you want to stay away from or
Really?
very much minimize
And drinking
it.
doesn't catch as much slack as smoking does.
It doesn't.
And it's often the biggest problem.
Right. I mean, it's very much a drug, yet somehow it gets away with not being classified as such. So,
Knowing GBV there as well.
absolutely,
It's
yeah.
from alcohol.
Oh, yeah. The problems alcohol brings.
Sure.
So if you can limit that, very much so. But in terms of foods, I would say, look, there's no right answer for one size fits all for everybody. But the Mediterranean diet is excellent. So in other words, a well-balanced diet comprising things like fruit, veg, unprocessed products, especially fish. In the South African context, you can add a bit of chicken, legumes, nuts.
Yeah, Indian people always say eat almonds, you'll be clever. That
Right?
that's the one. You know it.
So they're
Once
onto
you eat
something
almonds, you're sorted.
Right. Yeah. So look, I guess there's no secrets. Like this is what I'm saying here is not like a big secret or anything. However, it's one of those things that's simple but not easy, maybe. Because when you're sitting there and it's 9 p.m. at night, your fridge is calling you.
Oh, and the
all
thing
the
can
time.
call, bro. When you,
calls, eh?
especially when you're watching TV and the junk food's just like, and you're like, let me get some of that.
Like,
Sure.
no.
It's always later on in the day
Always.
as well.
Anyway,
Problem.
Yeah, temptation at night, always late at night. So something like the Mediterranean diet would be wise.
Yeah.
And yeah, really it's about staying away from the processed food, I would say, on the whole. Look, I mean, if you have the odd processed food, it's not the end of the world. It's more about long-term habits rather than like, the occasional cheat meal or like that's okay.
Yeah.
You know what I've realized that we as humans fail to accept. Like when it comes to health and stuff, just eat the green stuff and anything that grows, naturally.
Yeah.
That's it. That
Yeah.
really is it.
Yeah.
Like just make healthy choices, and you're right with the processed foods, but it's just something about us in our human brain that we always just end up with the chocolates
As
and the Coke.
as you know that, because I mean, you'll
We
have
know
those kind of
this.
meals and you know
Yeah.
how you feel afterwards
Yeah.
as well. Like when you have those other healthy options, you just feel great
Yeah.
afterwards and you continue to. It's just something deeper that makes you crave them.
So with retail, like I was obviously in retail for a while. When I was trying to put together my brick and mortar stores, there's this thing that says the least processed foods you'd find on the edges of the store. If you think about it,
Okay.
when you enter stores, every
Right.
single store, the edges of the stores are the least processed foods.
Mm-hmm.
You go from fruits and veg
Mm-hmm.
to the bakery stuff,
Milk.
to the milk, to the
Yeah.
cheeses, to the butters, to the meat,
Yes.
to the waters.
Yes.
And then obviously the cool drinks would be a problem. But that's often the pattern of work. Everything towards the center of the stores are usually the processed goods.
Okay.
Wow.
If you think
And as you're
about most
checking out
stores,
as well, right?
and as you're
Yeah.
checking out
As
that
you're checking
aisle,
out.
that aisle at the end
Temptation.
there is the
Yeah.
problem.
Woolworths
Yeah.
has nailed
Woolworths
that.
is
That
the problem.
Absolute temptation. Yeah.
That aisle there, you'll be like, cool, I'm not buying anything healthy. And then you're stuck there. And I feel like they're deliberate with putting 2 or 3 cashiers there. Because you're stuck between this thing for a nice 10
Well, that's
minutes.
why they have
True.
snake aisles too.
Yes.
So that you can.
Oh, you also know about those
Yeah,
things.
yeah, yeah.
They catch you.
Yeah, that's very true. Now that we're on this, Dr. Green, Wes, what are you seeing in your hospitals that is more and more becoming a trend and is becoming a challenge, from specifically with your field?
Plenty of. So I'm in state, right?
Mhm.
And state is where you have to be if you're specializing, and where many doctors choose to continue.
Why?
And for a number of reasons. I think we get used to it, and there's almost a comfort zone. There's a comfort in the chaos, but I think it's more than just that. I think people love it. You're in a sense giving back a bit. There is a temptation to go into private, which we can talk a bit about as well. But state, you get to meet the country when you work in state. I've worked in Cape Town, I've worked through KZN, and you get to meet the full spectrum of your South African society, and you see that people are suffering.
Mm.
People need help, and often it's just you, and it can be demoralizing trying to, and rewarding at the same time, trying to give these patients help. Um, so there's a lot of challenges, and in an overburdened health sector, and I'm not even sure where I would start with that. But I think from a neurology point of view, because there's only in KZN, there's only 2 units, Albert Lutuli and Grays. So I've worked at both, and both are excellent neurology departments. And we actually have quite a lot of collaboration. We go there Fridays for academic meetings, and we have a good relationship between the 2 units. So they will basically see all the neurology cases for half of the province, up, if you look at the coastline, and we will see the other half going more inland. And you can imagine we probably don't have the capabilities to be managing all the neurological issues in half the province. So we manage what we can. But for example, we might do outreach. You said you're from Northdale. We do outreach at Northdale, for example, Edendale, which is now Harry Gwala. We try to put ourselves out there, and we receive. So if we're on call, for example, we'll receive calls from all the neighboring hospitals who might have a neurological problem. And if the patient needs to come into us, we'll bring them in. So I think probably the fact is that we don't have the capabilities to manage the sheer number of neurological cases that come through. If we can manage them telephonically, then we will. But often, the thing with neurology is it's a tricky field, and you need time in it to get familiar with how your patients should look and picking up signs. So we often find that we actually have to see the patients that these doctors might call us with, because some things you just need like a trained eye to see.
Sure.
But when it comes to certain conditions, I mean, we see a lot of, like I was saying, we spoke about strokes earlier. We're seeing tons of strokes and younger people coming in with strokes. We see a lot of people coming in with epilepsy. Epilepsy is a big thing, as you can imagine. One I have a particular interest in. And with a lot of these, we either have the capabilities to manage it better, and they're just not getting the medication because of various factors related to the circumstances, or the medication exists overseas and it could be life-saving, but it's just too expensive.
Sure.
Which we're getting a lot of nowadays, like really groundbreaking, incredible treatments that can treat multiple sclerosis, Huntington's disease, and potentially offer, we don't like to speak of cure very often, but really exceptional results. And we're just not often able to acquire these medications for our patients purely on a cost basis.
Sure. Purely on a cost basis.
So we're looking at millions.
Yeah.
Millions for these medications.
With COVID,
well, there were billions. Sorry,
Yeah, no, it's
I'm
fine,
getting
it's
sorry.
You like numbers.
I'm getting aggressive.
I know where you're going with that.
Yeah, but this is not Dr. Green talking. This is me. There were billions in the form of 3 Lambos. And
that new hospital.
I'm going to leave that there.
That new hospital.
Carry on.
Yeah,
Sorry,
I think
Dr.
everybody
Green.
knows. Yeah, unfortunately, and we feel it, and that, as you can imagine, that irks us more than anyone. So it's a frustrating. There's a lot of frustrations in state. However, we have a soft spot for it, especially those whose heart's in the right place. And even if I was to try some time in private, which I may next year, I'll always look back fondly and even wish to still go back, and because I enjoy teaching, and it may still be an avenue that I could go back to.
You said epilepsy is what you have taken a lot of interest in. Can you tell us a little bit more about that? How does it develop? How does it start? What's happening? What's happening in your brain?
Epilepsy is, it's broad. So what it is really just a propensity for ongoing seizures, so like chronic seizures, really. And what's a seizure, right? So it's complex, but if you think about it, it's abnormal activity in the brain where the neurons are discharging, asynchronously and irregularly. And depending on where in the brain those discharges are happening, will determine the kind of symptom you have. So mostly fits, right? The body starts shaking. Usually that's because the whole brain is affected. The motor cortex is being involved, which controls your movements. So of course you're going to have convulsions. But you can have weird and wonderful kind of symptoms. You can have, if it happens to be in your visual cortex, you can have hallucinations. If it's in your auditory cortex, you can hear sounds. If it's in your temporal lobe, you can have weird, you know, perceptions of reality like deja vu, jamais vu. You can smell weird smells. You can taste blood. You can have a panic attack that seems like a panic attack. This is why we need to see these kind of patients, because it might be missed in all of these cases. And these don't sound like seizures to you, right? They sound like psychiatric phenomena.
Exactly.
So there is a lot of overlap with psych. So we call it neuropsych problems. So there's that. But basically, an epileptic will tend to have these discharges going off in a certain part of the brain from whatever cause. It could be a tumor, it could be an infection, which is chronic. It could be scar tissue. It could be a number of things, congenital abnormalities. So our job would be to find what's causing it and then control it. Luckily, we do have good drugs to control seizures, which makes it rewarding. But it's fascinating.
What's happening when they see when those who get seizures are seeing different types of lights, strobe lights? What happens? What's happening to the brain then?
Oh, so what you're describing, we can call that an aura.
An aura.
So but what an aura is really is where the seizure's starting. And if it happens to be in a part of the brain like your visual cortex, where you should be seeing things normally, that will cause, for example, are you talking maybe about the trigger? Oh, okay. Right. So some people have what's called photosensitive epilepsy. So photosensitivity to light. So if this had to start flickering, it could be a trigger to then set off a certain type of epilepsy. And there's various syndromes and types and even when we do an EEG, which is an electroencephalogram, it basically measures the brain waves. What we might do if we want to actually trigger a seizure is do like a strobe light effect. And we may pick up the seizure activity because it will help us make a diagnosis.
I remember being outside of a club long ago. And I was talking to somebody outside the club, and an ambulance came past, and this chick had a seizure from the ambulance light.
Hectic.
So multiple risk factors there. Yes, certainly the strobe light effect might have taken her over, but she's been drinking.
Yes.
She's probably not been sleeping. These are all sleep deprivation, drinking, etc., stress from who knows what. Maybe she just wrote exams the day before, and now she's coming off that. Jawling.
All of that.
All of those will definitely lower your threshold for having a seizure. So interesting, right?
Deja vu. You said it's the temporal lobe.
Yeah.
Where is that in your brain? That's not in the front? That's prefrontal
That's
cortex.
frontal, so it's more on the side coming in. So kind of where your temporal bone.
Yes.
Is underneath that. So there's two lobes on the side. Sit like that, and then go medially.
Okay, so so I see it in the brain. It's like over here somewhere.
Yeah, if this was like the brain, and it'll be like these two lobes that sit on the side.
But now when you say deja vu, for me it almost feels like deja vu can be real. So so what's happening?
It's funny when I take med students for TATS, every time I mention that, they're like, "Oh, but I have deja vu."
Yeah.
Does that mean I'm epileptic now? So no, it's like I said. I mean, some of these features are not necessarily a seizure. Some of them might be a psychiatric phenomenon. Some of them might be just stress. So it's up to us to figure that out. That would be our role. Where, for example, an EEG would help because it would pick up that abnormal activity, whereas someone who's just stressed or psychiatric would not have an abnormal.
Don't they say that you're allowed to have one seizure in your life though, without it being a problem?
Why?
Yeah, so usually that is true. Because everyone has the propensity to have a seizure, actually. It's just about thresholds. So in other words, heaven forbid, if we were exposed to something, for long enough, if you drank enough of a poison, let's say, or even alcohol, you would eventually have a fit. It's just that people who are epileptic tend to have recurrent fits at a much lower threshold. So someone who just has one seizure, typically we don't treat because the chance of them having another is quite low. If they have another one, or if with the first one you scan them and they've got a big tumor in the brain, or they're HIV positive, something like that, you will obviously treat them because the chance of them having another one is very high. And you want to limit that as much as possible.
What about depression, Doc? how does depression
Affect the brain.
affect the neuros the neuro
Yeah.
that system?
Yeah.
And I'm talking from your perspective, so I'm asking you from your perspective when you see depression, because some say it's a chemical imbalance.
Yeah.
But what are you guys seeing from a brain point of view when we talk depression?
Yeah.
What's happening?
Yeah. So depression is more than just sadness, right?
Mm.
And it's something that affects the whole body really, and you can go through each system and you can find ways in which depression tends to have negative impacts. And if you were to oversimplify it, you would say that it's just a chemical imbalance, but it's really so much more than that. And that's why, for example, just throwing antidepressants at someone in a hope to treat someone's depression is not going to work in the majority of times. I know there was when Prozac first came out back in the day, people who were depressed were like, well, my depression is clearly just a chemical imbalance. If I take Prozac,
I'll be okay.
it's going to sort me out, working on the serotonin system, right? And obviously, they saw some initial improvements, but we haven't cured depression, have we? So, yeah, depression has impact all across the body. In terms of the brain, it can put you at higher risk of many conditions. A lot of the degenerative problems we see, whether it's dementia, Parkinson's, over time, even with depression, you'll be at higher risk of those conditions. Suicidality and all that, of course, is higher with depressed people. But even if you go beyond the brain, heart, lungs, increased risk of over the long term of high blood pressure, early death, and you could go on, right? And we even have a thing called pseudo dementia, which is when patients will seem like they have dementia, but they're just depressed, and hence we call it pseudo dementia. So dementia is another big category of patients we see. And one of the big differentials we need to include there is someone with depression who may just, because they're so down, they may come across as having cognitive impairment. That's how down they are. So it's a big part. We ourselves, as general doctors, shouldn't be able to recognize and manage depression. And in neurology, we need to as well. But of course, we always get help from our psychiatric colleagues to help us with the more challenging cases.
Townhill, right there.
Yeah, right down the road.
Yeah.
Yeah.
That place is scary.
Yeah.
Yeah.
Right? Psych hospitals tend to be scary. Shutter Island.
Yeah.
Falkenberg in Cape Town.
Yeah.
Have you been to them?
What's that
Yeah,
one? I've been to all of them as well.
Yeah.
The one in Cape Town, Lensig
Yeah.
as well.
Yeah.
But Townhill, I had my craziest experience of my life. I'm gonna tell you guys.
How did you end up at Townhill, Josh?
Good question, Doc.
My partner's rotation.
Okay.
So she was there. So anyways, I pulled up there to drop off lunch, and I didn't understand how the hospital operated. Do you know what I mean? Like I just thought like the people would be like locked away.
Yeah.
You understand what I'm saying? Like when you go to a facility where people are not okay, you think they would be locked away like you see in movies, like people that are unwell are locked away. And I went to drop off food, and everybody was everywhere, bro.
Yeah, it's chaos.
It was chaos. A guy punched me on my shoulder hard.
Oh yeah.
Hard,
We've been punched a few
hard.
times by patients.
Yeah, like rocked my shoulder. I'm like,
Yeah.
bro, what's going on? And I thought it was a joke initially. And then she laughed at me. And she said, no, we're not allowed to like lock him up. But after I dropped off her food, this is where it got weird, because it's very eerie there, if you know what I'm saying. Town.
Sure.
It's
Why is
very
it?
eerie.
There's a lot of
is
space.
Why
Yeah.
is it like
There's
that?
just there's a weird feeling. I don't know if it's my mind, but it was weird, bro. Like
Yeah.
there's a lot of grass and there's a lot of trees and there's a lot of space, bro. And I'm getting in my car and there's this, when you feel someone's watching you? Do you know that feeling?
Mm-hmm.
There's someone
I
watching.
think that was in your head, though. Eh?
It was in my head.
There we
It
go.
was in my head.
There we go.
But there was a guy behind the thing who was just staring at me. There was like a cage
Oh,
thing.
so it wasn't in your head.
No,
Okay.
there was a guy staring at me, bro.
Okay.
And I asked like what's going on, and then she told me like what had happened to him, obviously, and what had caused him to be there. But people are really unwell there.
Big time. Yeah.
Like,
So
big time.
you can imagine they only have so many beds, right? And
Yeah.
I mean, you know how many mentally unwell, unstable patients you might find, even at the robot, even at the pick and pay.
Sure.
And those guys are just roaming around
Yeah.
and can't be housed there.
Yeah.
So you can imagine the ones that happen to be admitted are the
Yeah.
sickest of the sick and the most unstable
Yeah.
and a risk to themselves and to everybody around
Sure.
them. And yeah, we have a lot of respect for our psych colleagues and we
Yeah.
work quite closely with them because,
Sure.
as I said, there's a lot of overlap. But it's true. There's that feeling that you get when you go to those hospitals.
It is.
And
It's so weird.
It's quite something.
Because there's also something that I really wanted to talk to you about today, and I think it's a problem in a lot of communities, especially the ones that I've been in and from, and a lot of guys use marijuana as a, and now it's been brushed off as being a safe drug, and all
Sure,
of the,
sure.
I mean, it's become very commercial. There's shops everywhere. Back in my day, if you wanted like
Yeah.
weed, you had to like find a dealer, and
Yeah.
it was a situation. You had to drive
Absolutely.
out fast. Now you can go to the mall and buy weed, right?
Yeah.
Which is cool. I'm not trying to
Yeah.
say it's bad, but
Especially when you compare it to alcohol. let's say.
exactly. But like drug-induced psychosis.
Big time. Yeah. So our psychiatry consultant colleagues will absolutely not say that it's harmless.
Yeah.
So yeah, look, it's one of those. Okay, it's certainly not 100% safe, and it certainly has its risks. And when not used in moderation, or ideally not at all, it shouldn't be used. But in people that have a liability to developing psychosis, let's say you got a family history of schizophrenia, absolutely that would be the worst decision to puff on a joint. The occasional joint that people tend to have, and it's probably going to be okay. But yeah, it's interesting how it's gone from illegal to so accessible.
Commercial.
And there have been some studies, especially overseas, demonstrating that there has been an uptick in upstroke in certain conditions, psychosis,
from that.
that might be related to that. We're not quite sure. I guess correlation is not always causation, but there has been an increase in certain conditions that might allude to
Sure.
the use of marijuana. So it's a tricky one. So that's where we are.
Doc, what are some of the advancements you guys have seen in your field in AI?
AI, that's an interesting one. It's going to replace everybody, right? Replace the doctors.
Well, that's what it's been said.
Well, there's a funny
I
stat
think
right
Google
now
is working on
that
something.
they say that there's more content being produced by AI today than there is by individuals.
Yeah, it's
in the
gone
world.
over. Yeah, I heard
It's
that too.
just surpassed
It's
that
surpassed
threshold.
Wow.
humans, and it's only going to continue. So from a medical point of view, it's interesting, right? You've got it's kind of split in the middle, doctors at the moment. Some are really keen to bring it on board. Others are, maybe the older generation, are less inclined to. I don't think it's going to be replacing any doctors anytime soon. Maybe certain departments might feel it's a bit more, and I'll explain why. But I think the people who are going to benefit the most are those that are wanting to incorporate it and use it as a tool to make them the best possible doctor they can be, right? So neurology, where it might be of some benefit, I mentioned EEGs, electroencephalograms. So it measures the brain waves, right? And it's time consuming because you need to now go and look at each, we call it an epoch, a screen, a page for each second of various or time frame.
Is that the one where they put the things on your head?
Yeah, that's the EEG.
Yeah.
Yeah, so we need to now go and read that, and it's giving us information about different parts of the brain. So it's giving us electrical information, in a sense, brain waves. It's time consuming. We need to go back and look at each of those. If you've had a 24-hour EEG, we need to page through 24 hours of the EEG. Usually it's 20 minutes, but still, it is time consuming. If you can have a technology that pinpoints the abnormalities for you, casts a net maybe and catches them, and if you're like, okay, no, that's nothing, that's not abnormal, but the next thing you see is abnormal, that'll be great, as long as you're not missing anything. That kind of technology is great. It saves you a lot of time, and yeah, it might make you a better doctor. When looking at brain scans, so that's obviously something that we do, along with our radiology colleagues, of course. That's their specialty, but we need to be able to look at our own scans. We've got the clinical picture, so which they usually do not have. We know the patients, so we look at it with a slightly different eye, and it's a good practice to look at your own scans. But again, time consuming. If you had an AI tool that could pick up the abnormalities, especially the smaller ones, which you may miss, that would be amazing. So there's tons of potential. And I think the doctor who incorporates it into their practice is going to be the one that succeeds rather than the one that tends to want to shun it. And it's certainly not going to replace doctors anytime soon. At least clinical doctors, at least, especially not surgeons. I don't see that happening anytime soon. So
You're
it's
gonna need a human touch there.
Yeah.
I think so, and I think we're already seeing it in a way. I mean, we're talking about the content that's being seen. There's a lot of this AI slop at the moment. There's just so much nonsense that's out there, and I think
Tigers fighting
people
dogs.
are
Yes.
people are getting tired of it in a
Yeah.
sense, and I think you can extrapolate that beyond. And it seems like even with doctors, people will always crave the human touch,
Sure.
and as long as we can use it as a tool to provide a better service, I think that's the way. to
More
look at it.
enhancing than disrupting.
That's it. Yeah.
So specifically, is there anything you guys are seeing out there? Maybe obviously overseas that we could bring here that could help us, if money
Yeah.
wasn't a thing from
No,
an AI side.
we're seeing it. It almost creeps up on you, and you don't realize it. And before you know it, you're using it quite a bit. But for example, some radiology departments, not in state, at least I think in private, will have those screening tools, especially if you're doing like mammograms. So those X-rays that look at for breast cancer. Like I mentioned, in our world, picking up strokes quickly. So, like I said, when you're coming in with a stroke, you want to have that, but the clots busted as soon as possible, right? Because every second you're losing, hundreds of thousands of neurons. If you can have a technology that isolates the stroke and tells you that's a stroke, and therefore you know that it's a candidate to thrombolize or bust the clots, you would want to have that technology, right? Rather than using the human eye where human error comes into it. And again, it's something that will just aid you in making a better diagnosis, provide you with a more holistic approach. And yeah, so in the States, it's probably limited. But yeah, I think we're only going to see the myriad of possibilities in the next few years. It's exciting. Things that lend itself to, I also heard that there was a technology, it was developed by a South African, I think, an app that was able to pick up skin cancer just by taking a photo. You can imagine taking a photo, running it through an AI platform, lends itself to that kind of thing. And they were picking up cancers with a very high, we say, sensitivity, which is very promising. So exciting times.
You know what fascinates me a lot about the mind is the power of the mind. And I've read a lot about it before. Have you actually seen it happen in the medical space?
We see it every day.
Yeah.
Absolutely, yeah.
What is it? What is it that you're seeing? Sorry, what's
So there
well,
was
let me hear how you understand it, and then I'll tell you how I do.
There was this book that I read. I've just forgotten the name. It was The Secret.
Okay.
You know The Secret?
frequency, vibration?
Yes.
Yeah,
So
positivity,
there was this guy in The
manifestation.
Secret that was flying an aircraft over the canyon, I think, a small little plane, and he crashed. And they rushed him to hospital. He was alive, and he had basically like thrown his whole back out, like broke his back, like Mike Tyson vibe. And he said to the doctors that he will walk out of the hospital before Christmas.
Yeah.
And they said, it doesn't look likely, you know? And he said that he told himself every single day of the journey, I'm okay, I will heal myself, my body will heal itself. And he kept reiterating that to himself continuously. The day before Christmas, my guy woke up and left the hospital. Obviously, it didn't happen immediately, but he worked towards it.
Yeah.
But that's my understanding of the power of the brain.
Possible or impossible?
Look, every case is different, but your mindset changes everything. So absolutely, if you have a positive mindset, chance of you making a good recovery far outweighs the person with a negative mindset. It becomes a self-fulfilling prophecy at some point. Obviously, it's within reason. You sever your spinal cord, those
It's a different
those
conversation.
tracks are not just going to miraculously grow back together. On the other hand, it makes a huge difference. A positive mindset makes a world of difference, and I can believe that story absolutely. Within the realms of possibility, absolutely. And it's the reason why, for example, when you do a study, we call it a special study. We call it a randomized control trial, where you want to see if a new medication works. You compare it
Placebo.
to a placebo, right? And you need to do that because the placebo arm of that trial, those patients will improve. It's just purely being told that the treatment's going to help them. So clearly the power of the mind is there and it's complex and needs to be acknowledged. And then you would then compare the placebo effect with now your medication. So is there a difference over and above that of the placebo? So yeah, absolutely.
That's something that I just want to dig on again.
Mm.
Have you yourself seen a case where there was something miraculous that happened in your career thus far? Can you think of one?
Miracles, eh?
Yeah.
Sure. I would say that, yeah, for sure. I think we see it fairly regularly where something will just surprise us and we won't know why. And we may not always have an explanation, but a patient will improve. And we are always very grateful when such a thing happens. And yeah, like I said, and I think we have to have a lot of humility, especially in neurology, where we don't always know why something might happen. The brain is complex, the nervous system is complex. We may not always have the answers, and I think we need to be humble in realizing that. Doctors are not great at being humble, especially neurologists traditionally. But I think we need to be because we're constantly being humbled, and it may be sometimes in the patient's benefit where they just improve and we're not sure why. And I don't know if we would call it a miracle, but perhaps it's just beyond our understanding.
What happens when someone is brain dead?
So when you are brain dead, your brain is no longer able to fulfill its functions, right? And I suppose it gets a bit more complicated than that, and there's a few distinctions to make there, for example. But when you are brain dead, basically your cortex is not working. That's your gray matter, right? And it's not performing the functions that it needs to do, and it can't control the body any longer, in a sense. You may still be able to do some functions, being awake, sleeping, but you're not conscious to the world, in a sense. And essentially, you're comatose. There is another phenomenon, we call it a locked-in syndrome. I don't know if you've ever come across that. There was even a movie about it. Locked-in syndrome is when your cortex is still functioning quite well, but usually it's a stroke in the pons, and you are locked in your body. All you can do is move your eyes, but you're fully conscious.
Holy
So
smokes.
you would be understanding this conversation 100% right now, but the only way you'd be able to interact was maybe blinking your eyes, maybe looking.
Could you write? No.
No, absolutely not. So no function of the arms and legs.
Hectic.
So that's a locked-in syndrome. So you're not really brain dead because your brain is still there. Your personality is still inside. You're just essentially locked in to your body. And some people are still able to get quite good quality of life with that if they've got people who can support them. Usually. I haven't actually heard of many.
That is insane.
There's probably case reports of some that recover, but usually it's irreversible, especially in the case of a stroke, and
just imagine
quite devastating, right?
Seeing a tear coming down this oak's face.
And there's no facial expression.
Yeah, nothing.
Because it's like
flat. You might start seeing that as you get to know the person, their eyes, the eyes are the windows to the soul kind of thing, but you might start learning their ways and seeing that, certain looks of the eye might suggest happiness or sadness or agreement or disagreement, but that's all they got. And that's quite scary.
So that's you kind of being brain dead but alive.
Locked in your head.
Yeah, it's wild. It's quite, luckily we don't see it too often. It has to happen in a very particular part of the brain, but we see it.
You know, it's been fascinating me a lot. I think my algorithm is just inclined that way right now. But they say when somebody passes on, right, they have that final flashback of their life. Is that real?
Interesting, right?
Yeah, very. Yeah. And they say there's different things that they see.
Yeah.
Can you speak on that at all?
Sure. I guess I can give you a doctor's neurological look at it. I could give you a more spiritual explanation for it, because I guess they both are parallel ways of thinking in a sense. They don't have to be, mutually exclusive. But from a doctor's point of view, especially in neurology, we call to even diagnose brain death. Um, and I won't go into the details of all of that, and we deal with death a lot. Death is a part of life. Death is a huge part of life for doctors, and it's something that we get used to, and we have to deal with and try not to bring it home too much. We want to feel and care for our patients, but we don't want it to, you know, affect us too much that we can't perform our job
For the
adequately.
next person.
Yeah, but when it comes to death, it's an interesting one. It's more of a, it's usually not just a quick thing. It usually occurs over slowly over time, and where that point happens between when you're dead and when you're legally alive may not always be able to tell. We can infer clinically what we see. You'll tend to lose certain reflexes. We call them brainstem reflexes, for example. Your pupils. Now we said the eyes are the window to the soul, and they truly are in many ways. But you can look at, for example, sometimes the pupils of your eyes, whether they react or not to light. We can actually get a lot of information from the eyes, and that's a whole other story. There's other reflexes we can look at, and we can attach those EEG electrodes and look at the activity. We will usually see, as people tend to head that way, a flattening and eventually a flat line, a bit like how you would expect with the classic
The heart.
ECG.
heart from the TV shows. You don't always hear it like that, but it tends to flatten out and eventually it will, we call it, when the brain is dead, it's electrocerebral silence or inactivity, is the way we look at it on the EEG. And yeah, of course, it flattens out. You might find some people, or it's reported that you might see just a burst of activity just before someone dies. Haven't really seen that on an EEG, but it has been reported that can happen. When this is happening, oxygen and glucose plummets to the brain. And to your question, and I suppose you can speak to people who have had near-death experiences, and you hear a lot of these kind of stories where, whether it's the light flashing before them or having just a moment of pure sort of letting go and bliss and truly just letting go. It's been reported and multiple times that there has to be something to that. So what might be happening there is a couple things. From a neurological point of view, it could be that you release certain hormones at the time. This has not been proven, but it's possible. Endorphins, glutamate, who knows? These neurotransmitters could be released, sparking certain activity in the brain. Another concept is your brain might be disinhibited, right? So it's interesting. Your brain is constantly inhibiting itself and parts of the body to not do things. And when you get brain injuries, it gets disinhibited. So those things that it was stopping from doing now have free reign to happen, right? It's an I don't know if you've ever come across this concept. Someone who's taken psychedelic drugs, there's an idea that the reason they have all the hallucinations and all that is because the brain's actually disinhibiting it. Those switches are going off. Things that would normally dampen those responses are no longer there. And then all of a sudden you're getting all these phenomena happening. In a similar way, if the brain dies, you're disinhibited. And it's possible that in being disinhibited, all those processes might be happening and you get these strange phenomena. Whether it means that your whole life is flashing before you, it's certainly possible. I mean, it's likely that memories in a sense are stored in some way or another, or they are in the brain. And we can talk a bit about memory as well because it's super interesting. So it's conceivable that your life could flash past you, and it's conceivable that you could have memories that you didn't know you remembered happening, which is wild. And we were talking.
I was also just thinking about that. Sorry, Doc. I was also like memories. Damn.
We were talking about epilepsy earlier. That's why it's so interesting. Like I like reading books written by neurologists. Oliver Sacks is a famous one. He writes one book called The Man Who Mistook His Wife for a Hat. And one of the cases was of a woman who she was hearing music from her childhood for a few minutes a day, and she couldn't understand why. And it turned out that she was having seizures in the part of the brain that controls sounds. Wow. She was hearing music, and when she went to go look for the music, obviously it was nowhere to be found. No one else could hear it. Of a song that she hadn't heard since her childhood, and now was hearing it because of a seizure focus an irritated part of the cortex was going off,
How's it pulling from?
right?
Yo.
It shows how much we don't know. Memory is fascinating, and so it's interesting.
Um, when someone is in a coma, can they hear you outside? Can they?
It depends.
Like
Yeah.
when they ventilated.
Yeah,
Is
they
that true?
ventilated,
Yeah.
Okay.
and I don't know. Is there a difference when you ventilated and in a coma?
Yeah.
Don't they put you in a coma to ventilate you?
Usually, there's a lot of overlap there. Ventilator just means you've got life support providing your breathing for you, and being in a coma just means it's just a extremely low level of consciousness where you're
Yeah.
unconscious. So there's like
Yeah.
a spectrum of consciousness, and which we speak of in medicine, and coma is right at the end of it, just
Okay.
before death.
Oh shoot.
But coma can be from anything really. So it doesn't speak to the cause. It can be from a drug overdose, from an infection, from a, you name it. You can go into a coma. And then potentially, yeah. So what you were describing, there's sometimes people will then, because you are in a coma, the chance of you being able to control your ability to breathe and your airways especially is diminished, even though a lot of that is autonomic. So you then, for the protection of your airways, so you don't aspirate and swallow and cause problems, they will then intubate you and put you on a ventilator or life support kind of machine. So sometimes they'll induce the coma. We don't usually say that. It's like a lay person thing to say, but it's usually just to protect your especially your airway, in the hope that you can improve while you're in a coma and you can be treated. So in a way, it's not always a bad thing, because you can, for example, from a neurological point of view,
Brain swelling and stuff.
yeah, or someone who's come in, we were talking about epilepsy. Status epilepticus is when you have uncontrolled seizures that can't be controlled, and usually lasting for 10, 20, 30, 1 hour, 2 hours, who knows. The longer, the worse, right? Because there's damage happening to the neurons. And if you go into a coma, you can just quieten down the brain a bit if you induce that, and potentially treat the seizures along with your seizure medication. So it has its purposes, and that's why they might induce a coma.
Can they hear you now?
So whether they can hear you is an interesting one. Usually not, to be honest. Usually not. If, let's say,
they can't.
Yeah, look, there might be a time when you're in a coma, and you're not knocked out from heavy sedatives, where you might pick up on certain things, not consciously. But there might be stories where someone squeezes their hand and the blood pressure goes up. But it's usually not the case.
So what is happening when someone either squeezes a hand or moves after you say their name, or show some sort of hope? What is happening to the brain?
So in that case, they're probably not in coma. They're probably just recovering, or close to it maybe. But they probably have the cognitive abilities, still to react to a stimulus. Whether that stimulus might be from a loved one, or sometimes it might be perceived as being them recognizing it.
But actually,
but it could be something else. It could be a whole host of neurological
traumas,
myotonic jerks.
Right now,
that is insane.
So you got to take each one on its merit. So it's not completely impossible, but it would depend on the circumstance.
So at least though, if someone was in a coma and they then pass on, they were already in the last stages of their cognitive function. So they don't feel anything when they don't really feel anything when it's time to call it a day.
Agreed. And there's certainly a dignified way of dying. I know this sounds a bit morbid, but dying can be a blessing. And when we see, because there can be suffering leading up to it in some cases, and sometimes that's our job sometimes, not to prolong suffering. Obviously we want to keep patients alive and promote a healthy life, but we have to be realistic, and especially in a resource constrained environment like the state. It's not a decision we in neurology make all that often. It is from time to time, but I mean, our colleagues in ICU, for example, are making those kind of decisions all the time, deciding, okay, this patient, we're keeping them alive, but there's 100 other patients that need this bed, who may have better quality of life than this patient who we can see may not. So then it's a discussion you need to have with the families, and I think that's something you should always be doing. Bringing the families into discussions and keeping them
That's very hard though.
keeping them informed.
Like I feel like as a doctor, having seen it before, I feel like it's so hard getting, like, you almost have to switch off emotionally
Mm.
because you're going to
Yeah.
someone to tell them this guy's not going to make it. Like, you have to play the strong role here,
You
know,
do,
because
you
they're
do.
breaking down now.
Yeah.
Now,
It's interesting, like when it comes to families, a lot of doctors try and avoid families, and it can be a lot, right? But it's essential, and it goes such a long way to get early contact with family members and just to communicate them, just say where you are and admit to what you know, what you don't know. They really they respect that, and they're often just in the dark. I don't know if you see patients and family members in hospitals, they often look lost, and like they just often need a helping hand, and explaining what may be happening to their loved one or to themselves really does go a long way.
sure,
That is true.
it does.
Something very tragic happened a few weeks ago where someone was eating food and choked on a bone.
Hmm.
And she was choking and ended up, long story short, she's now in a coma and the brain is not functioning from just choking on a piece of bone.
Something innocuous, eh?
Hey?
Yeah, and I mean, so that's because at some point she would have arrested for whatever reason, and hypoxia, reduced oxygen to the brain. You've only got a couple minutes, man, and then you start losing neurons. It's why a stroke, you're losing neurons because you're losing oxygen. So it's amazing how that can happen, just like that, right?
Just like
Scary
that.
stuff, something so innocuous.
And you were speaking about how there's only 2 stations here in Maritzburg and down in Durban.
Yeah.
And these people are like from Port Shepstone.
Yeah. Port Shepstone has a very solid hospital, actually. We used to do some outreach there when I was working at Albert Lutuli. So, shame, base hospitals, we call them. So the district hospitals out there, they're doing all they can. And there's a lot of very dedicated, excellent doctors in state who do it for the love of doing it, or they do it because it's the next part of their journey on the way to specializing, etc., or because they have to during internship, ComServe. And you're going to hopefully bump into a very good one. While you're there, South Africa is known for producing excellent doctors. When they go overseas, they thrive. But yeah, we're being challenged. We've been challenged by the system and
resources,
overburdened, lack of resources system. But people are trying the best. And for someone like in Port Shepstone, they could potentially go to Port Shepstone Hospital, which is a very good hospital, and they will be helped. But it's not always the case. There's long waiting lines, and you do hear of horror stories, obviously. And obviously, if you are further away from these kind of places, then you're really struggling.
Yeah.
But ideally, I suppose ideally you want medical aid, right?
This is so funny, bro. But when I just started dating my partner, their family liked going on remote hike places, bro.
Yeah.
And I always used to say in my head, I used to be like, bro, imagine something happens in this remote place.
Yeah.
What happens then? And I said that to my partner. I said, bro, what happens if something happens? She's like, those things don't happen. I was like, okay. The first time I went with them, bro, we went like to the other side of the country, past the Transkei, deep down there to a little beach place.
Yeah.
And I said to her, bro, it's so dangerous if something happens to someone here because the nearest hospital is like 4 hours, 5 hours away.
Yeah.
She's like, oh, none of these things happen. Relax. I'm like, cool.
So you're the warrior in the relationship.
Yeah, like I always think of like,
usually the other way around, right?
Yeah, but I'm just trying to see like if something happens because I'm allergic to stuff, bro. So I'm just like, I have an EpiPen, one of those guys.
These things?
Yo, don't laugh, bro. Don't laugh, don't laugh.
I'm looking at you.
Are you laughing? Are you laughing? Oh. So, bro, this is the weirdest thing. They say they want to go on a walk.
That explains the bag and the stuff.
Yeah.
Anyway,
it's there in case I get up. So
you're safe, yeah. I mean,
you're safe. I've got everything, and I've got a doctor here. You're fine. So I say, we go for a walk, bro. This is the first time I'm meeting some of these people as well. When you just go to meet a girl's family, we're walking down this hike trail to the beach, and her aunt's behind us, and then her aunt misses a rock. And she she hurts her leg. We going to the bottom, and I hear this noise, and they say my partner's a doctor as well, so she looks back and she sees her aunt in a bit of distress, and she's like, "Oh, what's going on?" She's like, "No, she missed a rock, and it feels like she hurt her leg." So she goes and she has a look at it, and she's like, "Oh no, it's fine. It looks like you sprained it." Brew, I look at it, and the leg is hanging. Like, remember Luke Shaw in the
Broken.
Champions League?
It's just a spray.
It's broken. Like, it's hanging off.
Conor
I could see the
McGregor.
bone, like one of those. So I look at her, I'm like, Brew, I'm not a doctor here. But she's like, "No, it's broken," but she doesn't want to.
Oh, okay.
She doesn't want to, like,
How was she even walking? She
cause
clearly
panic.
wasn't.
She fell down. So we had to now. They were cousins of hers. We had to carry this aunt up this hike thing all the way to the top.
Mm.
Let me just tell you, it's the 26th of December as well. We go to the closest clinic that was like 3 hours away. There's no doctor.
Yeah.
There's nobody to
Which
help.
one did you go to? Which
Brew,
remember?
I've forgotten the name of it.
State clinic.
Yeah, it was a little
Government,
clinic,
yeah.
like a local one.
Okay.
And there was no one to help.
Yeah.
So, long
Yeah.
story short, people had to pack up the holidays, get back to KZN.
in the
Maritzburg.
blink of an eye.
In the blink of an eye,
Yeah.
freak accident.
No, we
I
can,
saw that
we
it was
can believe
done.
that. Yeah.
But that's how the holiday ended. That's why I'm just saying it's so dangerous to go to remote places sometimes.
Absolutely.
That's my inner brown boy.
Doc, sorry, can you tell us about memories? Can you expand on them and what
Sure,
happens in
sure.
the brain?
Memories, right? So memories are fascinating, and in many sense they create who we are. There's actually a process that they've mapped it out quite nicely now in the brain. It's obviously not all figured out, but there are processes that happen in different parts of the brain that contribute to memories, and it goes by the way of first being able to register something. Certain parts of the brain, reticular activating system, a few others that allow you to be awake and to register something. Then, so that's the first part. The next part is after that is I'm hitting a blank.
It's all right.
Your memory.
That's your memory. That's his memory. It happens to everyone, guys.
Yeah, man. No, the second one is encoding, right? So the thing about encoding is that it happens in the brain called the hippocampus. I don't know if you come across,
Yes.
which apparently is supposed to look like a seahorse. Doesn't really, but yeah, it's like a Latin for seahorse, Greek for seahorse or something. And that's a part of the temporal lobe we were talking about earlier that does that part of the memory process. So that's encoding. So it encodes the memory that you happen to get, whether that's something you've taken visually, something you've read. It's now encoded through the hippocampus. And there's this other thing called a PAPE circuit, which includes that, which is probably more detailed than I need to go into. And then it consolidates. So every time, for example, if you're learning something and you then repeat it, and you repeat it again, and you read it again, you then consolidating that information, and your chance of remembering it certainly increases. And then your ability to then recall, which is the next step, if you're trying to recall it years later, is another part of the brain, drawing on frontal lobe and its connections with the hippocampus, etc. So that process of registering, encoding, consolidating, and then recalling or repeating the consolidation allows us to remember things. And it's been quite nicely mapped out now, which is interesting. And yeah, it creates who we are, and it's fascinating. Yeah. So something like dementia, for example, are the kind of patients we would see who, especially in the case of Alzheimer's dementia, would have problems with their memory, and that'll be the first thing that kickstarts the whole process.
What would you say to someone who's trying to study for exams? How to memorize things the best way possible?
Yeah, so someone who's studied for many exams,
Yeah.
I can relate, and there are ways that are effective.
Sure.
And I think what you need to, so as you get older, your memory is not going to be like it was when you were 18, right? So you need to be prepared for that and be okay with that, and try and use different means to improve your memory using different strategies, for example. So you've got your normal memory using on those mechanisms that I spoke about earlier that you can often rely on, but sometimes it lets you down, especially in a stressful environment or an exam or something. And it's often useful to have handy aids to improve your memory in those settings. I love using like mnemonics, which are just silly word that has all the everything you need to remember on it. Mnemonics are just another way of you remembering something. So if you fail on one, you can use something else to help you remember. Environmental cues. It tends, if you change your environment, you can improve your memory. It's probably why you will always remember a way to go somewhere. Your brain tends to remember. It's probably based on our ancient ancestors, but our ability to find our way somewhere or find our way back home. It's very much something that your brain does very well. Whereas certain facts you'll tend to forget. So if you can somehow incorporate environmental cues into what you're learning, that definitely aids. There's such a thing called spaced repetition. Spaced repetition is one of those evidence-based ways of studying whereby you will learn something. An example would be then to learn it again in an hour, in a day, and then in a month, for example, or in a week, in a month. And I know some people say you'll remember it forever that way. Probably not forever, but it's that consolidating that we were speaking about earlier, and your ability to remember it very much increases. So that's great. The thing about a lot of these things is it takes time. So with a lot of things, when you're trying to remember somebody's name, for example, or trying to remember something for an exam, you need to just make a conscious effort to say, I really would like to remember this thing. And it sounds silly to say, but that's the first step. And then secondly, using one of these tools, which is going to take a bit of time and draw on other processes, parts of the brain to help you remember. Because if your sort of memory first step alone forgets, you've got these backup measures that you can use to try and help you remember.
I need to do that with people's names. I'm
Yeah.
terrible.
No, you are.
Like,
You
There's
are.
ways with
He
names.
forgot
I
your
don't know.
name. He
Yeah.
forgot your name within seconds.
Yeah.
Called
So the
you
thing
Nats.
is, so if you had initially
He
said,
even gave you a nickname.
I want to remember this name, it probably just went, you didn't even think of it. But the first step is just thinking, okay, I really want to remember this name. It's not always going to work. But then the next step is, there's funny things you can do. You can like attach something that sounds like it to the name.
What
Like,
what I try to do is just repeat it.
Yeah.
So there's
keep
that
repeating it,
repetition.
yeah.
Repetition is key. Like, I don't know, I could remember Yvonne Chaka Chaka or something.
Yeah.
Like like in your case,
Yeah.
Chaka Laka or I don't know, like something silly. It might sound silly, but the sillier it is, actually often the easier it is for you to remember it. So that goes a long way. And as you know, people love having their name remembered.
Yeah. So it's mnemonics
mentioned.
quickly, like a word like you'll say NUC, which means like net profit, and is that what it-
So like with me, I'll think of one that spells out a name. So if I have to remember 10 causes of a stroke, I'll put the 10 causes and then I'll take the first letter of each and then allow it to make a word.
Mad.
As opposed to, there's another
Nice.
one where people make a story.
Yeah.
My man runs down the road and has a donut or something. But then you have to remember the whole story. I don't find that as easy as just remember one word.
Sure.
And then you can go from that.
Sometimes you have to make a story though, because the
There's
word
no
letters don't
vowels.
make the
There's no vowels.
Yeah, that's when I've had to make stories.
Sure.
That's amazing.
Yeah.
Dr.
Wow.
Green, thank you so much.
Wow.
First of all, I want to thank you for your service that you guys do in the
Well done.
hospitals. Well, we've had hectic experiences, obviously, but with there's a new respect I've got for doctors and what they do and the hours that they work.
Mm.
It is long hours, right?
It's crazy. So thank you for the hours that you studied to get here, actually. So
Sure.
I mean, we don't know your marks, but we
they're
sure
high.
sure
They're high.
that you don't just get a degree in medicine that easily. So
No.
so thank you for that, and thank you for your
Thanks, guys.
time.
been a pleasure.
I've
Fascinating.
absolutely learned a lot today.
Fascinating.
But we would love to have you as our resident doctor. So
Yeah.
if we can have you in the
Sure.
future, that'll be great.
That would be
I would
amazing.
be happy to do that. It's been great, guys.
That was
Thank you.
amazing. Thank you for that.
Thanks, Doc.